So we're gonna go to common overdose. This, are you guys able to see the screen? What is the chat? No, I cannot hear you. Okay, two more. You can hear me now? And you can see the screen? Can someone send in the chat or say something? Okay, good. Sorry, guys, good. All right, so let's start with this one. Oh, you guys are sending question. Okay, Finas, this set's trying to get in. Participants. Okay, accepted everybody. Okay, so let's talk about common overdoses. Okay, so here we're gonna discuss acetaminophen, which is the most important among them because it's very common. It's the most common cause of liver failure in the developed world. Yeah, and even in Saudi Arabia, it's probably the most common cause. In Africa, maybe infection, but here, like Africa, like hepatitis and other infections. But in Saudi Arabia and in the developed world, we have acetaminophen as a common cause of liver failure. Aspirin, antidepressants, antipsychotics, and toxic alcohols are very common, especially these days. Toxic alcohol is a big issue in Riyadh. So maybe we talk about it. There is the lecture tonight. I can send you the link if you're interested. There's a webinar about toxic alcohol, specifically about methanol. So if you're interested, let me know. I can share the link with you. Okay. So acetaminophen is the most commonly used analgesic. It's the most commonly used medication probably worldwide. And again, it's the most common cause of acute liver failure. So you need to know it. You need to understand the basics of it. All right. So what happens when you take acetaminophen? Usually you get analgesia and you get antibiotic effect or treat fever. But if you take too much of acetaminophen, then liver failure could happen. How does it happen? Here we go. So someone took acetaminophen, okay? Usually the metabolism is by these: the glucuronidation in the liver, sulfation in the liver, okay? 5% goes unchanged in the urine, and a small percentage, different from person to person, like 5 to 10% or 15%, goes through the cytochrome B4 system in the liver and produce NABK. This NABK is the bad guy. This guy bind to the protein in the liver cells and cause the liver cells to die, cause necrosis. Okay, usually you and I, when we take acetaminophen, we metabolize it in these ways, and only small amount goes through this pathway. Small amount of NABK is formed. We have glutathione, so we don't get toxic. Okay, but if someone takes too much, then what happens is this pathway, especially, and also to some extent, this pathway gets saturated, so it cannot metabolize acetaminophen to the non-toxic metabolite. So what happened, more goes here, more goes through this pathway, more NABK form, we consume all the glutathione, and then we get toxic metabolite, not the non-toxic metabolite, because we have NABK that's free to go and damage the liver cells, and you get liver cell necrosis, okay? Normally, the dose you give to the patient is 15 milligram per kilogram, not more than 4 doses a day, not more than 4 grams a day. If they take too much of acetaminophen, they can take a huge dose, like 500 milligrams per kilogram. These patients will come very sick very early on. They will have decreased level of consciousness, and they will have metabolic acidosis and so on. But most of the time, we see patients who took an overdose, which is not huge, but anything more than 150 milligram per kilogram is overdose, okay? In pediatrics, sometimes we say 200 milligram per kilogram, but I want you to remember 150 because it's easy. That the toxicity from acetaminophen start at 150 milligram per kilogram. The toxicity from aspirin start at 150 milligram per kilogram. So that's why it's easier to remember. Usually patients can take it in acute overdose, like they take it at once. Within the same 8 hours, they took too much of acetaminophen. That's acute. If they take small amount of acetaminophen every now and then that's repeated supratherapeutic ingestion. I'm sorry, I don't mean small amount, that therapeutic doses. They take supratherapeutic doses, but at different times. So we call it staggered or repeated supratherapeutic dosing. Or chronic overdose, anything that if the patient took acetaminophen over more than 24 hours, that's chronic overdose, okay? It is important because in the acute overdose, we can use the nomogram and we can treat the patient according to the nomogram. In this situation, we don't use the nomogram, okay? So when you take acetaminophen, what happened? If you take any medication in large amount, the first thing you usually get is stomach upset. You get nausea and vomiting, okay? Not every patient with acetaminophen overdose will get nausea and vomiting. Some of them may not show it, and that's why when we have any patient with intentional overdose, we do acetaminophen level, because we're not gonna know, because they might be asymptomatic until they go into liver injury. And that's why it is a screening test. We do it for any intentional overdose, okay? But typically they have some nausea and vomiting. That's the first 24 hours. Starting after 12 hours and usually peaking at 24 hours, the liver enzymes start shooting up. And then in the third phase, they get fulminant hepatic failure. Their INR gets high, they start bleeding, their lactate goes up. And in this situation, if they're not, if they don't receive the greatest treatment, and even sometimes when they get treated very well, they can proceed to death. Or if they survive, they go to recover completely. There will not be permanent liver damage if they survive. But most, if not treated well or they come late, they will die in this stage. So you either die here or you recover. These stages are not written on stones. مو قرآن يعني. في واحد بيروح للstage 2 على 12 ساعة أخذ too much أو عنده قابلية زين. بس هذه in general. The first thing you're gonna see is nausea and vomiting, stomach upset, and then you go to phase 2 when NABKI start damaging the liver cells, because acetaminophen itself is not the one that damages the liver, it's the metabolite. So that's why it takes time to see the liver effect, at least 12 hours usually. So they start having right upper quadrant pain in phase 2 and elevation of the liver enzymes until they peak, and then phase 3 they go into liver failure, and then they either recover or die. Okay, so acute, what do? When they come to you, if they are within 1 hour, you can give them activated charcoal if they are stable and alert and oriented and you have no contraindication, and you ask for acetaminophen level at 4 hours or as soon as possible after 4 hours, okay? Because time is important. The longer time you delay NAC, the more the risk of liver injury. Usually NAC is very effective if giving within 8 hours post-ingestion. After 8 hours, the effect becomes less and less, okay? That's why we like to give it appropriately, but as soon as we can when we discover that the patient needs it. So when the patient take acute overdose, you do the level at 4 hours or as soon as possible after 4 hours. And if it's above the line in the nomogram, I'll show you in the nomogram, you give them N-acetylcysteine. You don't need to remember the doses, okay? If they ingest more than 150 milligram per kilogram and you cannot get the level, the acetaminophen level within before 8 hours, then you start NAC and you ask for the level. If the level is below the line, you stop the NAC. If the level is above the line, you continue the NAC, okay? And this is for acute overdose. If they took multiple ingestion over more than 8 hours period, or they ingested acetaminophen over more than 24 hours, then you cannot use the nomogram because the nomogram goes only for 24 hours. Then in these patients, you start NAC and you ask for acetaminophen level and liver enzyme. If the liver enzymes are not normal or acetaminophen is detectable, then you give them an acetylcysteine. So only 2 situations for you to make it easier. So in acute overdose, the nomogram starts at 4 hours and finishes at 24 hours. That's why when there is chronic, something more than 24 hours, the level cannot help us. The nomogram cannot help us. Okay, so if level is just detectable, if we detect that there is acetaminophen, then we treat. While here, between 4 and 24 hours, we draw the level on the nomogram. If the level is at or above the line, then we give them N-acetylcysteine, which is the antidote, the NAC, because the risk of getting liver injury and liver failure here goes up greatly, okay? If it's below the line, you don't need to treat them. They're fine. They can go to the psychiatrist if it's intentional overdose, or discharge if it's accidental. All right. Okay. Any question about acetaminophen? I want to know if you have questions about acetaminophen because it's important. I can stay late with you guys if you want, or I can give you the lecture at a later time. But I want to make sure you understand acetaminophen. Okay. You can ask me even later on for another lecture if it's not enough. Okay, aspirin used to be a very big problem, and we used to see a lot of patients coming with aspirin overdose in the past, actually before my time. But recently, because aspirin is no longer used as an anti-inflammatory and an analgesic, we see aspirin overdose less than before. We still see it, but it's less than before. Now aspirin mostly used as an antiplatelet in 81 milligrams dose, which is nothing. Before it was like 600 milligrams for anti-inflammatory effect. So again, as I said in acetaminophen, less than 150 milligram per kilogram does not cause toxicity. We're happy with it usually. But more than 150, this is when troubles happen. 150 to 300, mild to moderate toxicity, more than 300, severe toxicity, and more than 500, actually, they're more likely to die unless you dialyze them right away. Okay. But if the patient comes with an intentional overdose, you don't trust what they say. You have to do a level and you have to do a blood gas to make sure that they don't have metabolic acidosis and the level is not really high. But in accidental overdose or intentional that the patient is regretting what they did and you think the history is reliable, then you can rely on the ingested dose. But most of the time, if it's intentional, we do a level and we do serial level and we do serial blood gas. Okay, don't worry about what's written here. I don't want you to memorize it. This is oil of wintergreen. This is 98% salicylate. If a child drink this, they're gonna get salicylate toxicity or aspirin toxicity. Okay. Okay, what happened with before I go to the details of what happened, I need you to understand this. Acidosis is the process of producing acidemia. It's the process of causing the plasma or the blood to be acidic. Okay, acidemia is the result of acidosis, which is the result of too much hydrogen ion in the blood. So this is process, this is effect, a result, and the pKa, the term you might hear later on. I'm not going to ask you about this, but I want you to understand because it's important to understand how we treat aspirin. So pKa is the pH of the media, like let's say the blood, the pH of the blood, at which 50% of the drug is ionized and 50% is non-ionized. When we say ionized, meaning it has a charge, like positive or negative. Non-ionized, it has no charge. Why we care? Because drugs that has a charge can that cannot cross membrane. Drugs without a charge can cross membrane. So drugs that has a charge, imagine them wearing a big hat. So they are so big, they cannot cross the membranes. Drugs that doesn't have a charge can cross membranes. And for example, the pKa of aspirin is 3.5. So at a pH of 3.5, half of the aspirin is ionized and the other half is not ionized. Why do I care? Because I want aspirin not to cross the membranes and not to go into the tissues. I want it to get out of the body. That's why I want it to be ionized. And to make more ionized aspirin, I made the media, which is the blood usually, or the urine, I make it alkaline. Because when I make it alkaline, the majority of aspirin will be ionized. It will have a charge, it will have a big hat, and it cannot cross membranes. Okay, so that's what we're talking about. Here it is non-ionized, it doesn't have a charge, it can cross membranes. Here it is ionized, okay, and it has a charge, it has a big hat, it cannot cross membranes. Okay, just simple. If you have a hat, if you have a charge, you cannot cross membranes, we get rid of you. All right, so sorry, I don't know if you see this also, but it's just okay. So as I said, 3.5, at 3.5, 50% has a charge and 50% doesn't have a charge. The 50% that doesn't have a charge can go to the tissues, and that's why we don't like it. We increase the pH. We try to increase the urine pH to 8, so most of the aspirin is ionized and gonna get trapped in the urine and gonna get excreted, okay? But if the pH of the urine is 3.5, then a lot of it, 50% is gonna be absorbed. If it's less than 3.5, then more than 50% will be reabsorbed and will go to the tissues, okay? So just to get you to understand, you take aspirin, you get it through the GI tract, you ingest it. Usually aspirin has, if you take too much, it's delayed in absorption and the effect will be late. So you have to consider that when you're treating a patient. And then it goes to the blood. If the blood pH is low, if they get metabolic acidosis because you didn't treat them well or they come late, then the aspirin will become non-ionized and can cross the membranes and goes to the brain, and that's how the patient dies, okay? If the pH is good, you have the pH in alkalotic pH, like we want it to be between 7.5 and 7.55. So in the non-acidotic side, there is no acidemia, then the aspirin is mostly ionized and won't go to the brain and won't kill the patient. What's also important is if you give them sodium bicarb, you make the urine alkalinized. When the urine is alkalinized, when the urine pH is more than, usually we want it more than 7, about 7.5 or 8, then the aspirin is trapped in the urine because it has a hat. It cannot cross the renal tubules and go back to the blood. It will get excreted in the urine. And that's why we give sodium bicarb in aspirin overdose. If the patient already has severe acidosis, they need to be dialyzed because most of the aspirin is going to go to the brain, and that's how they die. They die of cerebral edema. And that's why when they come and they're sick, we give them a lot of sodium bicarb and we dialyze them. Okay. So what does aspirin cause? Acetaminophen goes to the liver and damage it. Aspirin, what does it cause? It goes to the mitochondria and inhibit normal breathing in the mitochondria, inhibit oxidative phosphorylation, causes lactic acidosis, causes hyperthermia, and that's why the patient will have severe metabolic acidosis and they will die from that. Okay. All right, what happened? Okay, so when someone takes aspirin, you know aspirin causes GI upset. Some people even get GI bleed from aspirin. So the first symptoms they're gonna get is GI upset. And then aspirin, once it gets absorbed, it goes to the brain and it stimulates the respiratory center and cause tachypnea and hyperpnea. They breathe fast and they breathe deep and they wash out CO2. So they might, if they come very early on, they may have just respiratory alkalosis, or they may have metabolic acidosis and respiratory alkalosis. The respiratory alkalosis is from stimulation of the respiratory center. So when you read their blood gas, you have to be very careful because the pH may look normal, but the bicarb is low and the CO2 is low. They get tinnitus or ringing in their ear or fullness in the ear because of uncoupling oxidative phosphorylation in the cochlea. And if you don't treat them well or they come late, they will have, the aspirin will go to the brain, they will have cerebral edema, they will have altered level of consciousness, they will have hypoglycemia in the brain because the brain uses glucose a lot. And when there is aspirin, they consume, there is uncoupling of oxidative phosphorylation in the brain, and they consume a lot of glucose. They can get hypoglycemia in the brain while the blood is still normal. So if they are altered, I usually push glucose also with the bicarb. And then they can get seizure from CNS toxicity. So GI upset, which makes sense. You eat something, it's in your gut first, then gets absorbed. Aspirin goes to the brain, stimulate the lungs, and they get hyperpnea and tachypnea. And then if you don't treat them well, at the same time that it does this, it goes to the cochlea and cause ringing in the ears and fullness in the ear. And if you don't treat them very well or they come late, the aspirin will go to the brain and kill them. Activated charcoal work very well to decrease aspirin level. So if they come early and they are stable, they are protecting their airway, and you still think there is still aspirin in their gut, even after 2 hours, if they're well, I usually give them activated charcoal. Sometimes even 3 hours, and sometimes I give them 2 doses of activated charcoal if there is no contraindication. Okay. Investigations, when they come to you and you suspect aspirin overdose, you do the aspirin level. The normal level is usually less than 2 to make it easier for you. And you need more than 1 level. So every 2 hours, you're going to be doing a level because there is delays absorption of aspirin. It causes spasm of the pyloric sphincter in the stomach. And it also causes bezoar, so there is delayed absorption. That's why you need at least 2 levels of aspirin that are normal before you can say the patient is safe to go to psychiatry or go home. Okay? So if there is acidemia or acidosis, acidemia is the better term, then aspirin will go to the brain and to the cells, other body cells like the liver, the muscles, and they might have a low level of aspirin, but they have severe acidosis. So you don't rely on their level of aspirin because it's all in the tissue, it's not in the blood. Okay, so if the pH is low, aspirin level is useless. You need to give them bicarb and dialyze them. So again and again, low pH, aspirin goes to the tissues, goes to the cells, goes to the brain cells and kill you, and goes to the other body cells. Every 2 to 4 hours, you're doing aspirin level until it peaks and then start going down. You need at least 2 normal levels. Treatment, A, B, C, D, E, as everything else. Activated charcoal, it's good for aspirin if there is no contraindication. Sodium bicarb, and if they have acidosis, or they have CNS toxicity, or they have renal failure, any organ damage, they will need dialysis as well as the sodium bicarb. So when do you stop? When the aspirin level is normal, at least 2 levels. They are asymptomatic and they don't have metabolic acidosis. So take home message for aspirin: serum and urine alkalinization is important to get rid of the aspirin, to get it excreted in the urine. Hemodialysis can be life-saving in severe toxicity, regardless of the aspirin level. And if you let acidosis and acidemia goes on, the patient will die. And make sure that you ventilate them very well, because what they're doing, they are breathing very fast to stay alive because they wash CO2, because CO2 causes acidosis too. They release CO2 with the breathing. If they stop breathing because they're tired or they are altered, then you need to breathe for them, but you need to do it fast. You need to give them a rapid respiratory rate when you intubate them. Otherwise, CO2 will go up. They have already acidosis, which is metabolic acidosis. Now they have respiratory acidosis and metabolic acidosis, and they die. Some patients, they arrest after intubation because we didn't give them sodium bicarb before we intubate, and because we intubate them and we didn't breathe with the same rate that they were breathing before intubation. Okay, that's it for aspirin. Okay, antidepressants. In general, antidepressant will cause increased serotonin. They can cause serotonin toxicity. They usually some antidepressant can increase norepinephrine too. We call them SNRI, serotonin norepinephrine reuptake inhibitors. SSRIs, serotonin reuptake inhibitors, are the common ones used. And also some of the antidepressants will increase dopamine. Okay. Should have allowed everybody in. Okay, so the types of antidepressants, I'm going to give it, there's a lot of information here, but the most important is what you see in this slide. This is TCA, which is less used now, but it's a killer because it's a sodium channel blocker. So it causes arrhythmia and causes seizure. And we treat it with Sodium bicarb, because it's a sodium channel blocker, we give them sodium to overcome the blockade, and we give them benzodiazepine for seizure. Okay, we cannot dialyze it because it's all in the tissue, it's not in the blood, so dialysis doesn't help. It can cause, it actually commonly cause anticholinergic toxidrome, so they might be altered and tachycardic at the same time. Always get an ECG with antidepressant and antipsychotic overdose, because both antidepressant and antipsychotics can prolong the QTC, and certain antidepressant and antipsychotics can prolong the QRS, leading to VTAC, and when they prolong the QTC, they get Torsad. I want you to be at SSRIs usually cause serotonin toxicity. They can cause prolonged QTC, but citalopram and escitalopram are the worst SSRIs in overdose. In overdose, they're bad, these guys, because they cause seizure and they cause QTC prolongation more than the others. So patient can get seizure and can get Torsad. You treat these with citalopram and escitalopram with magnesium sulfate if they have Torsad or prolonged QTC, and you treat the seizure with benzodiazepine. So ECG is very important. That's why everybody with overdose get an ECG. Vilavaxine is an SNRI, serotonin norepinephrine reuptake inhibitors. It's vilavaxine, desvilavaxine, and duloxetine. These, the SNRIs, cause what? Prolongation of the QRS, because they act like TCA. They have sodium channel blocking. Anything that blocks the sodium causes QRS prolongation. Anything that blocks the potassium causes QTC prolongation. So remember, SNRIs, like TCAs, cause QRS prolongation and can cause seizure. Treatment, again, because they block the sodium channel, we give sodium bicarb, and because they cause seizure, we can give, if they seize, we give benzodiazepine. There is an atypical antidepressant, which is called mirtazapine, usually causes sedation and overdose. Usually it's not dangerous. Bupropion is an antidepressant. It causes seizure in therapeutic doses and more seizure in overdose. So if you see bupropion, be ready for treating seizure, and it also causes wide complex tachycardia. We give them sodium bicarb for that. So, but remember, bupropion is bad for seizure. Okay. Treatment, ABCs, supportive care as usual, ECG, check their glucose. There are cases of antidepressant causing hypoglycemia. Check the paracetamol, because if it's intentional overdose, we want to make sure that they don't have paracetamol overdose. And benzodiazepine for seizure, okay? We don't use phenytoin. Sodium bicarb if they have a wide QRS, and magnesium sulfate if they have prolonged QTC. Okay, the antipsychotics, they don't act on serotonin usually. Some of them may have serotonergic effect, but the most important is they block dopamine, okay? There are two types of antipsychotics, the old typical antipsychotics, the new atypical antipsychotics. The old typical, the best example is haloperidol. They cause a lot of extrapyramidal side effects. They prolong the QTC. So that's why always ECG is important. If the QTC is very long, we need to watch for Torsad. If Torsad happens, we treat with magnesium. And if wide QRS or VTAC, we treat with sodium bicarb, okay? So extrapyramidal side effects. Newer generation antipsychotics, the atypical antipsychotics have less extrapyramidal side effects because they are have less affinity to D2 receptors, so they have less extrapyramidal side effects, except risperidone. Risperidone actually is close to the old antipsychotics in terms of extrapyramidal side effects. I've seen so many extrapyramidal side effects from risperidone. Anyway, the treatment of extrapyramidal side effects is easy. You give them anticholinergic drugs like diphenhydramine or benzotropine. We'll talk about it later. So all antipsychotic can cause anticholinergic toxidrome, and even the antidepressant can cause anticholinergic toxidrome, extrapyramidal side effects, prolonged QT, which we said if there is prolonged QT and Torsad, we treat with magnesium. They can cause hypotension, we treat with fluid and vasopressors. ABCs, supportive care, ECG, glucose again, get a paracetamol level, and benzodiazepines for seizure. If doesn't work, barbiturate. If doesn't work, propofol. We don't use phenytoin, okay? Sodium bicarb if they have prolonged QRS. Magnesium sulfate if they have prolonged QTC. If they have extrapyramidal side effects, you can use diphenhydramine or benzotropine. It will treat the extrapyramidal side effects. Okay, that's all for antipsychotics. This is the last thing we're going to talk about, and then I'll give you a chance to ask any questions you want. Toxic alcohol is you may be heard in the news that we have some cases of toxic alcohol. It's very common to see it everywhere in the world because people try to make alcohol in their home, and then instead of producing ethanol, which is the alcohol that people normally drink, they produce methanol, or they produce methanol usually, which is toxic alcohol. If people drink radiator fluid, motor radiator, this is ethylene glycol, and it's toxic alcohol. Why we call them toxic? Because they have toxic metabolite. Actually, alcohols are all toxic because they cause you to be drunk. But ethanol does not have toxic metabolite. It's metabolized to acetyl-CoA, which goes in the Krebs cycle, doesn't cause much trouble. These guys have bad toxic metabolite, methanol, ethylene glycol, and that's why we call them toxic alcohol. We don't like them. They kill a lot of people. Isopropanol is the alcohol that we use to clean our hands in the hospital, the hand sanitizers. Some hand sanitizer have ethanol. In the past, most of it was isopropyl alcohol. Isopropyl alcohol does not have significant toxic metabolism. It's very irritant to the GI tract, and it's known to cause pancreatitis. So gastritis and pancreatitis with isopropanol. So isopropyl alcohol is also called rubbing alcohol because it's the one we use to clean before procedures and to clean our hands when we see patients. It's used in solvents, in hair products, and paint thinners, and antifreeze. الانتيفريز اللي هو اللي نحطه في مويه المساحات. طبعا في السعوديه احنا مرات نحط مويه عاديه ما يجمد، بس مثلا في كندا وامريكا لانه البرد شديد او روسيا يحتاجون يحطون الكحول لانه الفريزنج بوينت حقته عاليه فما يتجمد في الراديتر. تمام؟ والبوينت بويلينج بوينت حقته عاليه فكويس. Most of alcohols in general they get absorbed very fast. Sorry? Does someone want to say something? Okay. What I was saying is alcohols get rapidly absorbed from the GI tract, usually because they're liquids and easily absorbed. So the effect will happen right away. That's why giving activated charcoal is dangerous because they might get drunk right away and they might not be able to protect their airway. Again, isopropyl alcohol is metabolized to acetone, which doesn't cause metabolic acidosis. It causes osmol gap, but no anion gap because it doesn't cause anion gap metabolic acidosis. It does not have significant toxic metabolite. But it's osmotically active, just like ethanol and methanol and ethylene glycol. They all have osmotic activity and can increase the osmol gap. Okay, methanol. It's found where? In paints, في البويات، في موية المساحات، في اللي يسوون الكحول بالبيت، الهوم ميد الكحول، احيانا يسمونه مونشاين، لانه يبغى يسوي ايثانول بس بالغلط يطلع ميثانول، ما يبخره كويس، ما يخلي الميثانول يتبخر، فيبقى الميثانول يكون كمية كافية انه يسوي toxicity. Symptoms include كل الالكحولز it makes you drunk, altered mental status. الميثانول بالذات الميثانول لوحده مو زي باقي الكحول بالزياده على الالترد mental status يسوي لك ايش visual disturbance. Patient may come, they say we are blind or we have blurry vision, or may say the classic thing that we see a snowstorm. طبعا في السعوديه ما يعرفون شو snowstorm لانه ما قليل ما عندنا snow، فبيقول لك انه I have blurred vision. They also have abdominal pain, nausea and vomiting because all alcohols are irritating to the GI tract. Now, methanol can cause toxicity without causing a lot of alteration in mental status. يعني أقلهم drunkenness، أقلهم سكرة عشان تصير واضحة لكم هو الميثانول. أكثر شيء الأيزوبروبايل، بعده الإيثيلين جلايكول، بعدين الإيثانول، بعدين الميثانول. الميثانول أقل واحد يسوي drunkenness, but most patients will come to you drunk. Most of them. If you examine their eyes, you might see papilledema, but most of the time you're not examining their eye. You're busy treating them because they're sick. Ethylene glycol is the other toxic alcohol that I want you to remember. So toxic alcohol, methanol and ethylene glycol. Ethanol, we don't call it toxic because it doesn't have toxic metabolite. Okay. Usually ethylene glycol has 3 stages. It doesn't always come بالترتيب زي البارستامول، يعتمد على قديش اخذ ومتى جالك. ف initially they will have CNS depression, then they may have tachycardia, tachypnea, hypertension, or they even go into hypotension and respiratory depression, and then later on they develop renal failure. Okay, I don't want you to remember all the details, but remember انه كل الالكوهولز في البدايه patient سكران بس altered level of consciousness، بعدين تبدا disasters بعدين لما تطلع التوكسيك ميتابولايت. اوكي، سو لما يجوا لك في البدايه اغلب البيشنت بيجوا لك بميتابوليك اسيدوسيس، اغلبهم حيكون عندهم اوريدي ميتابوليك اسيدوسيس، ما يجوا بدري. هو لو يشرب على طول ويجي لك يعرف انه شرب ميثانول او ايثيلين جلايكول، بيجي لك عنده اوزمول جاب بس ما عنده اناين جاب. بس اغلبهم يجي متاخر، يكون اوريدي الميثانول الايثيلين جلايكول ميتابولايز للتوكسيك ميتابولايت، فيكون عندهم اوريدي اناين جاب، وغالبا يكون عندهم بوث اناين جاب اوزمول جاب. اوكي، وش الاوزمولر جاب؟ الاوزمولر جاب نحسبها بهذه الفورمولا 2 times sodium plus glucose plus urea plus ethanol. We add it to the calculation لانه كثير من اللي عندهم توكسيك الكحول عندهم ايثانول also. اوكي، هم يختصروها هناك يقول لك 2 salt صوديوم، 2 salt sugar bun اللي هو الخبزه BUN urea BUN and alcohol. هذه this is how you calculate the osmolarity. And then osmol gap is osmolality اللي measured in the lab, measured not calculated, minus what you calculate. If it's more than 10, then we consider it high and we worry about toxic alcohol. I don't want you to memorize this. This looks hard. Don't worry about it. It's just to say that all alcohols are metabolized by alcohol dehydrogenase into aldehyde, and then by aldehyde dehydrogenase into the final metabolite. Methanol and ethylene glycol and methanol get metabolized to toxic metabolite. Methanol gets metabolized by alcohol dehydrogenase to formaldehyde and then to formate or formic acid, which is the disaster, which is the thing that causes metabolic acidosis and blindness and everything. Ethylene glycol gets metabolized to glycolic acid. Here the acidosis start by aldehyde dehydrogenase to glycaldehyde, then by alcohol dehydrogenase to glycaldehyde, and then by aldehyde dehydrogenase into glycolic acid, and then to glyoxalic acid, and then oxalic acid. This oxalic acid with calcium form calcium oxalate crystals and get deposited in the kidney. And that's why we say the third stage of ethylene glycol toxicity, you get renal failure because of the deposition of calcium oxalate crystals. They can get also low calcium because it precipitates with the oxalate and the serum calcium become low. They may have rigid muscle rigidity and they may have a prolonged QTC2 and arrhythmias. Okay. Here, just a summary of what I said. Methanol is metabolized by alcohol dehydrogenase. It's spelling mistakes here to formaldehyde. Alcohol ADH is alcohol dehydrogenase. And formaldehyde is metabolized by aldehyde dehydrogenase into formic acid, which is the bad guy for methanol. I encourage you to attend the lecture tonight about methanol. It will be very nice. You will hear about the history. You will hear about how methanol is formed, and you will hear about the treatment. Okay. Ethylene glycol, again, the same thing. It gets metabolized by aldehyde dehydrogenase to glycaldehyde, and then by aldehyde dehydrogenase into glycolic acid and oxalic acid, which forms calcium oxalate crystals and precipitate in the kidney. You can even see calcium oxalate crystal in the urine, but that's not how we diagnose it. If we see it, it's good. If we don't see it, we're treating based on metabolic acidosis and high osmolar gap, or metabolic acidosis and suspicion of toxic alcohol. So this is just to explain to you what I said before. When they drink methanol and ethylene glycol here, they just drunk, they have osmolar gap. When the liver starts metabolizing methanol and ethylene glycol, the osmolar gap goes down until osmolar gap gets to 0. But with this metabolism, we produce formate and oxalic acid, and then as we produce them, the anion gap start go up until you get severe acidosis with high anion gap. At some point, you may have both osmolar gap and anion gap, but at the end, you will have high anion gap and no osmolar gap. In the beginning, you may say osmolar gap without anion gap, which is very rare because patient doesn't come until they are sick. Okay, Charcoal is bad. Don't give it to alcohol patient. It doesn't work. It just put them at risk of aspiration. What we do, how we treat toxic alcohol, I will go back because I want you to understand the pathophysiology. Oops, I'm going forward. Sorry. We are almost done. Sorry, guys. Okay. All right. Okay. All right. So here we block alcohol dehydrogenase by using either ethanol or fomepizole because they have these drugs, the ethanol and fomepizole have higher affinity to alcohol dehydrogenase than methanol or ethylene glycol. So if you block this enzyme, you prevent the metabolism of methanol and ethylene glycol into the toxic bad metabolite, and these get excreted in the urine slowly. It takes time, but they finally get excreted in the urine. So what we normally do, if they already have metabolic acidosis, we give this to prevent further metabolism of the to the bad guys, and we dialyze them to remove methanol, remove the toxic metabolite that already formed. If they come very early on, you can use the ethanol or fomepizole. Typically, we use fomepizole to prevent the bad metabolites. And if you don't have dialysis, you could continue using fomepizole until they excrete all the methanol and ethylene glycol they have, and then they become normal. Or if they develop acidosis, then you have to dialyze them as well. Next. معلش جهازي خربان فما أقدر أسوي back and forth. Okay, so we said activated charcoal is out. Use fomepizole or ethanol. We typically use fomepizole because ethanol is an alcohol. It's going to make them drunk. It can, because we give it IV. You can give it oral, but it can cause them to be drunk. They can aspirate. If you give it IV, there is risk of arrhythmias. So that's why it's not the best treatment. The problem with fomepizole is it's expensive, okay? But if you count that when you give patient ethanol, you're going to put them in the ICU, you're going to do ethanol level every 2 hours, you're going to have to deal with the complication. So the price becomes the same. So we prefer to use fomepizole if we have it. Additional treatments for formate, which comes from methanol. Formate, we give folate, F and F. We give formate, for formate, we give folate. It's a cofactor that helps change formate into water, and then it gets excreted in the urine. For ethylene glycol, we give pyridoxine and thiamine. Actually, I give thiamine to everybody with alcohol, whether it's ethanol, ethylene glycol, or whatever alcohol, I give them thiamine. But remember, folate is added to, I mean, it's not a big deal if you don't remember it, because the most important is you block ADH and you dialyze them. But these are cofactors that are helpful. Folate for methanol and formate, and pyridoxine for ethylene glycol. Dialysis eliminate everything. It removes methanol, ethylene glycol, and their toxic metabolites, okay? The indication for dialysis, if you have a patient who already has metabolic acidosis, a pH of less than 7.25, or high anion gap, then they need dialysis. If patient has any end organ damage, like visual disturbance, renal insufficiency, their vital signs are not normal, or they're hemodynamically unstable, they have significant electrolyte disturbance like hyperkalemia, or they have a very high level of more than 50, then they need dialysis, okay? A lot of the patients will actually need dialysis. And that's it. I am free if you want, if you have any question for any of the lectures. Sorry, I had to go fast because there is a lot of topics. في أحد عنده سؤال؟ فهمتوا شيء؟ Are you guys muted? Because I hear sometimes the sound and sometimes not. Rayyan, you are not muted. Rayyan Al-Qahtani. في مشكلة ما أسمع. أوكي. أبى أروح الشات أشوف إذا في شيء. بس أنا ما أحبه لأنه متعب صراحة. أنا I like to hear you. الله يعافيكم، بس معقولة ما أحد، يا أما ما أحد فهم ولا شيء، يا أما أنكم مرة عباقرة على طول استوعبتوا كل شيء. ولا مستحيل تتكلمون او ما تقدرون وانا ما ادري. I don't know. Any question? في واحد حاطط meiosis هناك. Yes, opioid causes meiosis, but be careful. You don't rely on meiosis to diagnose opioid toxicity. You most importantly look at the respiratory rate. Yeah, we treat hypertension. Treat hypertension with what? That's weird. Yeah, we treat hypertension with benzodiazepines in case of the sympathomimetic overdose. Cocaine, amphetamines. If you give them benzodiazepine, you reduce the sympathetic tone and their blood pressure comes down. If it doesn't work, then you can use phentolamine, which is alpha blocker. أو nitroglycerin. ترى معليش اللي يجون كل شوي يدخل واحد فقاعد أدخلهم كل ما أشوف أنتبه الواحد أدخله فأعتذر إذا كنت أخرت. في أسئلة ولا شيء ولا خلاص نمشي؟ أوكي. عندكم محاضرة الدكتور عبد العزيز آل الشيخ لأن فيها كتابة وفيها معلومات يمكن تحتاجونها. Can someone answer? أنا ترى ما أسمع شيء، ما أدري المشكلة من عندي ولا من عندكم. If you can type it في الشات. خلاص أوكي. أرسلها لمين؟ راح أرسل لكم محاضرتي ومحاضرة الدكتور عبد العزيز. هم بالعادة يعطونكم إياها ولا لا قبل ما أخبص الدنيا؟ I'll ask him anyway. I think I know. I think he would know where to send it. I hope إنكم تعلمتوا شيء. إذا تبغون تحضرون الويبينار الليلة على الساعة 8:30 تقريبا حيكون جدا مفيد لأنه في حالات